difficulties today. My name is Sarah. I'm one of the vascular residents at Imperial College London, and I'm delighted to be part of the EmPowHER team. This is an educational initiative by Vein and Lymphatic University that really is trying to promote education and evidence-based, so high-quality information with respect to venous and lymphatic disease. First of all, we'll start off with a couple of introductory videos by Drs. Kabnik and Kanata, who are great supporters. So if the technical team could kindly share those now, please. Thank you.
Hello, everyone, and welcome to today's session. My name is Dr. Lowell Kabnik, and I'm the chairperson of Vein and Lymphatic University. VLU is a premier educational platform whose mission is to deliver groundbreaking, high-quality content utilizing the talents of a diverse global team of health experts focusing on venous and lymphatic disease and treatment for the medical community and its patients. The goal of VLU is to make a positive impact on the global medical community by accelerating venous and lymphatic education through highly accessible and interactive live webinars and lectures, informative videos, and other premium channels of community engagement with the aim of empowering, inspiring, and advancing understanding of venous and lymphatic disease and treatment. Our initial series is titled EmPowHER, which was developed by Ruth Bush, Sarah Onida, and Leanne Alizio. This is a series of webinars crafted and directed by our women colleagues for all. On behalf of VLU's Executive Board, we thank you for joining us.
Buenos días, queridos amigos. Yo soy el Dr. Víctor Kanata, presidente de Vein and Lymphatic University. La plataforma y el grupo de trabajo de Vein and Lymphatic University es un grupo de profesionales de alto nivel a nivel mundial que se encuentra desarrollando programas de enseñanza, de capacitación y de preparación de diferentes tipos de webinar, trabajos humanitarios y enseñanza en el campo de las varices y los linfáticos. Este grupo de trabajo tiene una calidad y una capacidad excelente. Nos encontramos permanentemente trabajando en demostrar la excelencia y la capacitación de todas las personas dedicadas al tratamiento de las varices y de los linfáticos a nivel mundial. Por eso les decimos y les agradecemos al grupo de trabajo. Les pedimos que nos sigan en nuestras plataformas y en nuestros diferentes webinars y que se acerquen al grupo de trabajo de Vein and Lymphatic University. Generalmente lo manejamos en forma compleja, teniendo la posibilidad de demostrar el trabajo de las diferentes diversidades etnológicas, demostrando las capacidades científicas a nivel mundial. Así que, por tanto, les doy la bienvenida. Espero que nuestro trabajo tenga sus frutos en relación a la capacitación, la calidad de la enseñanza y así como también la llegada a nuestros diferentes pacientes a nivel mundial. Así que un fuerte saludo para todos. Por favor, recuérdense de que la capacitación y la enseñanza es algo que realmente nos va a ayudar y va a demostrar que nuestros pacientes cada vez reciban mejores diagnósticos y mejores tratamientos en el arte del tratamiento de las varices y los linfáticos. Un saludo para todos y que Dios los bendiga.
Great, right. So to start our session, what I'll do is just share my screen for a minute. So first of all, Vein and Lymphatic University kindly acknowledges the support of Boston Scientific for this webinar series. And we have a fantastic mix of panelists today who will very kindly be presenting themselves. But we have here Dr. Pounds, Dr. Hedayati, Ms. Antonucci, and Dr. Mendoza, who will be giving us some presentations in areas of their interest and expertise. And this is the agenda for today. So without further ado, I'll let Dr. Pounds start her presentation today. Thank you.
All right, thank you, everybody. Very much appreciate the opportunity to be here. Hoping to, even though we practiced, be able to share my screen. Of course, now I'm not seeing it because that would be too much. All right, let's see. All right. Can everybody see the screen?
We can indeed, but if you could do that display settings things we did before, that would be fantastic.
You bet. For some reason, there's quite the delay on my program to make that happen, but I'm up and running now.
Fantastic, thank you.
Okay. Again, thank you very much for the opportunity to be here. Part of this really important series, and it's quite the honor. So my topic today is duplex ultrasound hemodynamics, technical and clinical strategies on how to do best venous mapping here in San Antonio. And I work mostly at the VA, along with Dr. Hedayati. We share that privilege. But I also work with residents and fellows. I'm the program director for the Vascular Fellowship. And I've actually been asked to cover some additional topics besides techniques. So I've included a few slides to start this lecture with the RPVI process that was required for board certification. I was asked to put that part in there. And then just some overview of diagnostic and preoperative mapping, and then some clinically relevant types of waveforms in deep and superficial. I have no disclosures. So when we look at a traditional certification pathway for the RPVI, not quite 40 years old, the RVT certification grew steadily as the need has increased with our aging population and prevalence of PAD, and a couple inflections, but generally there was an overall increase in the total of RVTs over time. Now, this reporting scale cut off at 2011, so it's obviously 10 years old, but as of there was almost 25,000 total RVTs. And then when you look at what used to be the traditional pathway for physicians, you could only become a registered vascular technologist. And I highlighted here 2001, where I took the boards. I took the RVT, but a very small group as you went through the 80s, first beginning with vascular certification. And then there was definitely an increase. And part of my fellowship, it was expected that you would, of course, take it. And then after 2001, you did see this sort of sharp increase in the number, and this is cut off over here, I apologize, but increased number of physicians that were taking it. And here you see in 2006, they started the RPVI. So the number of RVTs kind of flattened out once the RPVI process became available. And today there's probably about, a good 1,800 MDs who have an RVT to their name. When we started seeing, they had the initial exam in 2005, but then 2006, you could see now again, RPVI has become prevalent, and for reasons that we'll talk about here in a second. So if we look at who is certified, so who takes it? Unlike the RVT that was almost exclusively vascular surgeons, and to take this test, you have the RVT, you have to have 1 year of ultrasound clinical experience. And before endovascular, that was a common part of pathway for fellowships that were 2 years. Back when I was applying in the late 90s, you had a choice. You could do a 1 year fellowship or a 2 year fellowship, and there were not that many 2 year fellowships. And so most of the 2 year fellowships would include, a year in the ultrasound lab. In fact, my salary was paid for by taking vascular lab tech call during that first year, because that was not Medicare supported. But now if you look at the pathway for exam interpretation and testings, led to certification in other specialties. So if we look here, cardiology is actually more prevalent than vascular surgery. And this is through March of 16. And there's a large group of unavailable, so we're not sure what this group is. Then you have sort of a splattering of other specialties, including vascular medicine, just general radiology, interventional radiology, and then the grouping of other that may be perhaps doing a vein lymphatic type of mostly practice. When we look at the performance and pass rates by specialty, we could see that interventional radiology has the highest and probably the most background for working with ultrasound and physics, whereas cardiology and vascular surgery were tied at the time of the pass rate when they did that. So if you look at 70% of vascular surgeons actually failed the RPVI in 2015. And since you need it to sit for your vascular boards, that equates to money. So that's definitely, felt to be a problem at the time. And so when you mapped out by year and fail rate, it was fairly consistent for about 7 years. But in 2013, you start seeing almost a doubling in the number of test takers. And then you see that the orange, which is the failure rate, had definitely increased between 14 and 15. Now, over here on the APCO website, there is a general increase in the pass rate. From 2012, you can see here the NADAR going down was 77%, 75, and then now it's up to 89, 88%. And part of that, there's been an educational push for things like didactic series and encouragement of the Association of Program Directors in Vascular Surgery. So if we look at the difference, and I'm fortunate enough, I've taken both tests about 15 years apart. And if you ask what's on either one, here's a breakdown of the differences. The RVT is typically taken by ultrasound techs. So it's more heavily weighted for anatomy, physiology, and pathology, which the top three top two here account for basically 40%. Whereas if you look at the RPVI, that's only making up about 18% of the test. But where you really get the most here for the physicians that are doing it is your integration of data. And that's really what you're being paid for when you receive money. There's a diagnostic fee and then there's a physician interpretation fee. And that's what you're doing, is interpreting the data. So that's where the most of the money is at on studying for this test. And so in 2020, here's sort of a list of what was covered on different parts. Again, the patient care, the data, integration of data, and then protocols. In physics, it says 10%, but physics is actually part of the entire thing. So don't think that you can get out of the lecture series that talks about it. So other things that are interesting or people become confused on is accreditation for the lab and for personnel. They're two different things. And so when we look at for the vascular laboratory and for the facilities and the personnel, the overarching group was called the ARDMS. And this is from the Strandness Vascular Laboratory book, which is a few years old now. And so they have the ARDMS listed as for, how people would get credentials, personnel, an individual. Whereas your facility would go through the Intersocietal Accreditation Commission, IAC, and that's where your lab would have its main accreditation seal from. Now, if we look at vascular techs, so you have a basic physics component, and then you have your specialty. So here they could be breast or OB-GYN, adult echo, or whatnot. So here's for your vascular techs. And then they would go on to become a registered vascular technologist. Whereas you have the separate for the physicians, which is the physician's vascular interpretation exam, which then leads you to become an RPVI. Important thing when you go to the ARDMS, they say important news about your account is that it's been transitioned to the APCA as the overarching agency that oversees what you're doing. And then it directs you to the website where it tells you, you know, your certification and everything. And you have to pay money each and every year to maintain this and keep your CME up to credit. And I know a lot of people will take the test and then let that credential slide, including a few of my partners. But in general, it's really, I mean, they do add up. It's not that strongly expensive. And once you have that credential, then you maintain it. I do know one of my former, my first fellow who graduated, we actually took the test together because I was interested in seeing what was on it. And when she changed jobs, she had let her credentials, she did not maintain it. And the new job required that she had to retake it. So you do not want to have to take this test again. So if you look where to start, and you know, if you go to the APCA website, you know, that goes into the list of what is needed for this. There's an overview, the prerequisites, which it'll go through. You have a patient log, sample letters from program director, and things that you need to do. It's actually listed fairly nicely on the website. And if you take one good thing out of this, you do have to provide a medical license number, an unrestricted license number. And that has held us up, I know, and some of my fellows now going through, if they were not allowed to use their institutional license. And so some states, Texas, California, New York, some states are really long and arduous to get your medical board, medical license. So if you're waiting, you know, months and months to get that, you may have had a window that you thought you were going to take the test, and then all of a sudden can't do it because you don't have the medical, you don't have the license, which again costs more money as a trainee, is never fun. In my lab now, I actually have cardiology fellows that I agreed to let come through the lab in return for helping staff some of the vascular clinics at the VA. And so what they want to get out of it is, you know, cases to log to take the RPVI. What I'm hoping is that they're going to be actually adequately trained and know what they're doing instead of just signing what a technician has given them, so that the reports make sense and have something behind them. Because again, we're not watching it live like radiologists. We're, you know, getting a report of static images usually. So when you look at your case documentation for your 500 cases, you can surely use, the APCA has a sample Excel sheet where you could put on, or probably most efficient for vascular trainees is to just log it into the ACGME website, and then it will give you a summary. You need your 500 cases, and dutifully logged are 510 cases from one of my trainees, where they put everything in there so that they just kept track of it that way. And that just seems like you're hitting two birds with one stone. All right, so I'm going to transition from that and go on to the vein mapping protocols. You know, each lab that you work in, and I've worked in many lab now over the last 25 years, will have a protocol on how to do this. And, you know, it's a very highly reproducible study between observers. And this was confirmed in a study in 2012. Now, interestingly, it was reported in Vascular Health and Risk Management, but each lab will have a listing of policy that they have and go through. So when you do it between people, it has a high sensitivity and specificity and accuracy when people are trained and have their certification. And then each lab will have what they want to include in their protocol for mapping. So it'll be as simple as, you know, introduce yourself to the patient, wash your hands, have them, you know, undress and get lay down. Like, there'll be step mapped out each step, but what's actually included in the test, it will be written down as well. And so this should be all marked down for what you're going to do. You're going to measure the venous size, the reflux, which part of the veins you're going to look at. So here, if you're going to look at common femoral, great saphenous, then you're going to go down to different areas. So each lab will have this mapped out, or if you become the director, you'll help develop that protocol if you start a lab. All labs that I've ever worked at or seen always start with the DVT scan first. And they're going to do a simple, they'll start with their B mode ultrasound. up at the saphenofemoral junction, and most will include the contralateral femoral vein. And then they'll go over and do a series of compressions. I think we're all pretty familiar where they put the two walls together and look for that. Then they'll turn on some color flow, and then they'll take some Doppler, some waveforms through that. So that's going to be your basic study that you're going to look through to do that. One of the tips or the tricks when you're given, different sonographers that will do this is to look. You can tell what part of the vein they're on or where they're at on the leg based on the position of the femoral vein. And remember, it's not the superficial femoral. It's that one died. It's the femoral vein. But you can see here the walls co-opting all the way together. This is more common femoral or just below the bifurcation with the profunda SFA. And then as you get further here, you can see the arteries on top of the vein, and that's further down in the thigh. And this is a nice demonstration of a phasic waveform. Labs will also list their criteria for acute DVT. I think everybody's probably familiar at this point. Your primary diagnostic modality for doing is that the veins are not compressible, which we just showed, but there's also some secondary hints such as equiluscent thrombus. The vein will be distended. So here you can see clot inside, but the femoral vein is distended around that. It's trying to dilate and let flow go around that. You'll also see a loss of your Doppler spectra or your color flow from it being blocked into there. This is a nice picture. They had great views of axillary thrombus. And then you're going to have your listing for chronic DVT. This is a nice table from the internet showing the criteria of your different echogenicities and how the lumen size, compressibility. Techs can have, well, different labs may never see the patient, and then techs will also have, if you get it wrong, if it's acute DVT, the patient dies. And so a lot of techs will have a hard time differentiating, or they'll be afraid to call between acute and chronic. For our lab, we did education and talked about, how the difference, how they looked. And I think this is a great diagram that I've been actually putting in the clinics to show people between acute and chronic, because patients sometimes are sent around to ERs and start on anticoagulation for people who don't understand what's written down there between acute and chronic, and the chance, the chance of one breaking off and the other is actually well formed and actually endothelialized. Then you go to your reflux protocols. And so the original JVS article in 2003 that's quoted quite frequently for your times, which they had 40 healthy and then 60 limbs in patients with venous insufficiency, and then went through, and there's a lot of statistics in it, but basically came up with the times of 500 milliseconds or half a second, and for the superficial, and then for the deep. But what they're looking for is they'll go through your superficial anatomy, looking at different sections. Most will include the saphenofemoral junction, and then going down into proximal thigh, mid-thigh, calf, again, depending on what your lab decides to do, and look for the valve to close. So this is your classic waveform where the valve closes and no blood will go backwards. Here's your flow pattern towards the foot. Whereas in reflux, that flow continues to go through the valves that are not co-opting and meeting together. When you look at how this is actually done, ideally, this is how you would think it to be done. I think in most labs, the patient's usually supine with a Valsalva. And so sometimes you have to realize your lab and what they're doing. If you're really suspicious, someone has a venous ulcer and they say there's no reflux, you have to send them back for a standing study or something like that, a late day study, to see if it makes sense. Some labs will be beneficial or have the ability to have this standing platform. I know at the VA, we have in all three of our rooms, the automatic cuff deflator. And so what that does, it sends that augment of blood past the vein valve when they're ultrasounding and then looks for it to come backwards. For tech ergonomics, it's certainly much better for the patient to be higher, for them not to have to lean over if they're standing. Trying to do a good venous reflux with the patient standing on the floor and the tech doing that is very challenging. your texts will hate you. So when you look at reporting, it should be a fairly nice report listing, which side of the leg it is and which veins you're looking at, trying to get them in order. This is from one of our labs where we bounce back and forth here between the saphenofemoral junction, and then we go to the small saphenous, and then the great saphenous again, back to the small saphenous. Ideally, it just takes time for the technical director to work through all that. But ideally, you want your valve closure time to be listed with, in a definition. So we do it in seconds, and then the diameter and the impression of like the basic venous. And so medical insurance companies for approval are requiring these diameters and these times. So you want to make sure it includes all that. And there's a diameter. So if we look at the peripheral effects in cardiac function, so the most common study performed in the vascular laboratory is probably lower extremity venous duplex ultrasound. And the reason why we do it is for leg swelling or edema. And so the most common finding really in a vascular lab isn't necessarily a DVT or, some other palpatory aneurysm. It's really heart failure. But I think we tend to not list that or talk about that when we see it. We just say no DVT, no reflux. And so if you really look at the hemodynamics of this, you want to look at the normal waveforms and then your abnormal spectra. And so each portion of the vein that you're on, what you will expect to have for your normal phasic waveforms as you get further away from the diaphragm, this will actually change. But you should have a normal phasicity to it with inspiration, if they're having the patient Valsalva, whatever it is you're trying to do for this. But if you look at your abnormal venous spectra, you're going to see different things. So here in the top, they have a deep venous reflux. So you can see they've done a large augmentation of blood flow here, and then the flow stays above the baseline. One of the big things looking at cardiac pulsatility, and again, that's your CHF, an AV fistula. I think most labs are probably pretty good at pointing this one out. You can have gross tricuspid regurg going on. You can do that, or continuous flow, which would indicate a more proximal obstruction. And then listing for other hemodynamics here, that on top of these waveforms, this is a great one here that shows this cardiac pulsatility. And so I'm always thinking CHF. And so somebody who has a very large BMI or has a lot of different things going on, and you see these waveforms, we'll actually comment, pulsatil waveforms consistent with, cardiac dysfunction, please clinically correlate. And that at least gets the referring doctor a clue, or not a clue, but a pathway to go through to see what the patient's doing. So for conclusions, ultrasound is your best ally for venous disease. Study for the RPVI and record your cases. Have a non-restricted license. Adhere to your well-defined but not cumbersome vein mapping protocols, and then look beyond the reflux world to report other findings in cardiac issues. All right, and that's our Audie Murphy VA. He was the most decorated World War II soldier, and has a movie and a book to hell and back if anybody's interested in learning more. Thank you.
Thank you so much for that fantastic presentation on hemodynamics and the different patterns. If we could now get Dr. Hedayati to kindly share her slides and move on to the next presentation, and we'll have the questions at the end.
Sure, thank you so much. Let me share my screen. All right. Can you guys see my screen? No. Yes?
Yes, ma'am.
Oh, hold on. Oh, God. Hold on. Sorry. Apologies. Stop sharing. I'll introduce myself because I think I recorded my talk on my slides. So once I open my slides, it's going to just have my voice recording on it. So I'll just let that talk. I wanted to thank the organizers for this wonderful invitation. I'm Nasim Hedayati. I'm professor of surgery at UC Davis. I'm chief of vascular surgery at our VA here in Sacramento. I spend most of my time, like Dr. Pounds, at the VA, and I'm the director of the vein center at UC Davis. So I spend one day there doing veins. So I will share my screen now because it's going to have me talking. So I'll just let it talk. And at the end, I'm happy to answer questions. So I'll just be quiet now. So let me share my screen again.
Vascular surgeon at UC Davis, and I'm the medical director of the UC Davis Venous Center. Today, I will be talking about superficial venous treatment and the use of duplex ultrasound in the fall. I have no financial disclosures. The objectives of my talk are a brief overview of frequent forms of treatment for superficial venous disease. I will also talk about duplex ultrasound follow-up of their different modalities of treatment. Now, review some of the ultrasound techniques post intervention. In general, when we see patients with C6 disease, we start with a history of physical, along with a venous duplex ultrasound to assist with superficial venous reflux. Our technologists usually provide us with a diagram and a description of the veins, which are useful in order for us to determine what modality will best serve the patient. These descriptions are useful in allowing us to know whether the great saphenous vein is tortuous and whether it's straight. Also, the size of the veins are important for documentation, as sometimes insurance coverage is dependent on size criteria in order to cover the procedure.
Doctor, turn on the sound, please. Share your sound on your video, please.
Cases. I do venous seal.
Nasim, can you hear me?
Yes, yes.
Please share your sound with me, please.
Hold on. I thought I was sharing my sound.
In the share screen, down in the left, please click.
Hold on.
Share share my sound, please.
When you share the screen, you should.
When I share the screen, my video plays my words. So what I can do is, let me do something else. Would you rather me just play my slides and then just talk over it myself?
Yes, that might be better. If you would prefer, I can bring up your slides if that's helpful.
Those slides also have video on it. So let me just give you 1 minute.
No problem at all.
To get rid of this. So let me go back to this. Let me close this. I'll just find my presentation that doesn't have the sounds. Okay. Can you guys see these slides?
Yes.
Okay.
Yes.
I'll just go through these. Okay. I don't know why it's still recording, but so I'll start from here. Can you guys hear me pretty good?
Yeah.
Okay. So
Excellent, right? Excellent.
I'm sorry. Did someone
You
ask
are-
something?
Yeah, no, just your sound is okay right now.
Okay. So when we typically see patients, when we get our reflux studies, our ultrasound techs do a really nice job drawing out sort of a map of what the saphenous, the accessory saphenous veins look like. And that helps us a lot with trying to figure out what best modality to use. And the sizes are important because a lot of times, at least in the States, insurance companies want to know the size for coverage of these procedures. These are the most frequent procedures I do in my clinic. I do RFA with venous catheter. I do Varithena when indicated for special veins that are tortuous, or sometimes I see people that have had previous ligation and they have a remnant. I use Venous seal, and I do a lot of phlebectomy and sclerotherapy using ultrasound in clinic. Our follow-up algorithm has been, we do an ultrasound in 3 days after RFA and Venous seal, and that's how it works out best for our practice, since we do our procedures on Tuesdays and Fridays, and we tend to get the procedure follow-up duplex either on a Monday or a Tuesday, Monday or a Friday, I'm sorry. For Varithena, what we found from experience is that it's better to just wait a week, sort of based on what also the company's IFU is. So I'll present a couple of cases. This young woman is a 17-year-old. She has Kibble-Turnani syndrome of the left foot and ankle with capillary and lymphatic malformations up to the knee. She had been previously seen by one of my partners who had done some sclerotherapy. She now presented with worsening left lower extremity varicose veins, heaviness, swelling. She's pretty active in school. She wears compression hose and had some improvement of her symptoms, but she was still pretty unhappy with the pain and stuff. She had some discoloration and some discrepancy in the size of the leg and some prominent varicose veins. She had a duplex ultrasound that demonstrated reflux in the great saphenous vein, and she had this large perforator in the thigh that had 7.3 seconds of reflux and measured almost a centimeter. And there was multiple tributary veins that were connected to that perforator vein. I chose to actually treat her with cyanoacrylate or Venous seal because I also wanted to get that perforator to close without the fear of getting anything. Like if I'd used Varithena, I was always afraid to potentially get some foam in her deep veins. And with Venous seal, if you sort of work through it well enough, you can get that proximal part of that perforator closed. And then I use ultrasound to foam the thigh varices, and she did really well after that. These are just some ultrasound images of other patients that I've treated with Venous seal. You can kind of see the saphenofemoral junction here, and then the GSV is interesting because you don't really see thrombus. You can kind of see this glue-like material in it. This is a patient that I treated also, and you can kind of see the saphenofemoral junction. This is a patient I treated with the small saphenous vein with Venous seal because she couldn't tolerate any injections. You can kind of see the glue here, and the top is thrombus, and this was also non-compressible. The second case is a 49-year-old woman that had prominent lateral and medial thigh varicose veins. She had a prior left great saphenous vein RFA. She'd been very compliant with compression hose therapy, but she was still having a lot of pain and heaviness. She had this anterior accessory saphenous vein that had significant reflux, so I decided to treat her with Varithena, and then this was kind of early on in our experience. I brought her back to get a ultrasound 3 days later. So when we brought her back, you can kind of see the saphenofemoral junction here, and this accessory here is thrombosed. But what we found, which was interesting, was that this thickening below the saphenofemoral junction, the femoral vein here, and you can kind of see it right here on the femoral vein. It was hard to kind of know whether this is thrombus or this is just wall thickening. You can kind of see it here again. So I chose to treat her with Eliquis for 2 weeks. I repeated the ultrasound again in 1 week. It was essentially unchanged. You can kind of see it here. The vein was compressible, but you can kind of see this thickening here. She was completely asymptomatic and she did really well. I didn't repeat the ultrasound, and after 2 weeks, I had her stop the Eliquis. So this is why we sort of went to just follow them up in a week after their Varithena treatments instead of bringing them out 3 days according to the IFUs. I do a fair bit of phlebectomies in clinics. I do a handful concomitantly with the GSV or SSV reflux treatments that I do. I use tumescent using the linear high frequency probe because I think you can see it really well. But a lot of times I'll stage them because I think after you treat the axial reflux, these definitely get smaller, and then you don't need as many micro stabs as you would typically do. And then they sometimes even can be treated with simple sclerotherapy. So sometimes I will wait. So there's very few that I will do concomitantly now. I use the linear, the hockey stick probe for doing ultrasound guided sclerotherapy, and I'll use a butterfly because then I can connect it to a stopcock, and that allows me to foam the sclerotherapy agent much better. So I think it's important to, set up guidelines for follow-up after venous interventions that work for your practice and your institution. It's important to also know with the different modalities that you use, what the post-intervention ultrasound looks like. Dr. Pounds had shared a wonderful image of a glue in a saphenofemoral junction, but I couldn't find it for the life of me to share with you guys. And then having, of course, a standardized protocol in your practice for treating EHIT or EGIT, which is the endovenous glue-induced thrombosis, I think is very important. Thank you so much, and I apologize for all my technical difficulties this morning or this afternoon.
Not at all. Thank you so much for your presentation, Dr. Hedayati, and don't apologize at all. It would be great if we could now move to Mrs. Antonucci. If you could kindly share your talk. And I just want to remind everyone that if you've got any questions, please put them in the chat or in the Q&A. And we're keeping tabs because we'll have the discussion later, but we will address them. Thank you.
Hello, my name is Linda Antonucci, and I've been working in the field of phlebology ultrasound since 1987. I'm an ultrasound consultant and educator, and I currently sit on the board of directors for the American Vein Lymphatic Society. And the only disclosure I have is I'm a paid consultant for Hemodynamics. My presentation is recorded, so hopefully I will be able to stay on time. I would like to thank the Vein and Lymphatic University for the honor of presenting today. I would also like to thank Dr.
We can't see the slides, we can hear it, but if you press share screen and then make it start again, that would be fantastic. Thank you.
Share the sound too.
Turn up the sound, okay. I would like to thank the presence of retrograde flow in the veins of the leg was first Okay, one more time. Sorry, apologies. Having some glitches here. I'm so sorry. I would like to thank the Vein and Lymphatic University for the honor of presenting today. I would also like to thank Dr. Lowell Kabnick, my mentor and friend, for his generous guidance and support. My talk today is on segmental reflux and, whenever possible, the identification of its source, which is a critical component for setting up an accurate treatment plan. I'm going to begin by reading a few definitions that will lay down a foundation for understanding the complexities of segmental reflux. Retrograde flow is the flow of fluid in a direction opposite to that considered normal. The presence of retrograde flow in the veins of the leg was first recognized in 1891 by a German surgeon named Friedrich Trendelenburg. The definition of reflux is a backward flow. The definition of reflux and retrograde flow are very similar, but are they the same? Hopefully, this short presentation will give us food for thought regarding this question. A cutoff valve closure time of 0.5 seconds is the criterion for significant venous reflux for both the deep and superficial venous systems. Dr. Erica Mendoza has suggested that a definition of 1 second may avoid diagnosing pathology at borderline values when there are no clinical signs. I, for one, agree with this comment wholeheartedly. Venous insufficiency can be defined as a fixed venous outflow disturbance of the limb. It is caused by the malfunction of the venous system that may or may not be associated with venous valvular insufficiency and may involve the superficial or deep venous systems of the lower limbs or both. In his commentary titled The Anatomical Extent of Venous Reflux, Dr. Fedor Lurie describes the terms axial reflux and segmental reflux concisely. Axial reflux is uninterrupted retrograde flow from the groin to the calf, but he notes that axial reflux always involves incompetent valves, whereas segmental reflux. So now we are presented with two types of reflux, axial and segmental. Are they the same? More importantly, should they be treated the same? Now that we've reviewed the terms and asked two essential questions, let's dig a little deeper by uncovering a few common errors made during the ultrasound evaluation that oftentimes leads to unsuitable treatment. In addition, let's add a third question to the list. Can we apply criteria created in the standing position to a lower extremity venous evaluation performed in the supine or reverse Trendelenburg position? Poorly performed reflux examinations are not uncommon. It has been proven that the use of the supine or reverse Trendelenburg position can lead to false positives as well as false negatives. The definition of reflux, as defined by most experts, is retrograde flow greater than 0.5 seconds elicited in the standing position. It is not that reflux cannot be elicited in the supine and reverse positions. It is that it does not meet the true definition of reflux. Here are 4 images that were submitted to the Intersocietal Accreditation Commission, along with their Vein Center accreditation application. These images were submitted to depict significant reflux. A more appropriate image depicting significant reflux would resemble one like this. Now we are going to look at a few slides and try to determine if they represent genuine reflux from an incompetent axial vein, or is the reflux from another source. Ask yourself the question, is the reverse flow patterns depicted in this image axial vein incompetence or a case of overload from another source? The source of reflux in the great saphenous vein displayed in this image is junctional. This is the classic case of axial reflux, which was defined by Dr. Fedor Lurie on an earlier slide as uninterrupted retrograde venous flow from the groin to the calf. In this case, it happens to be all the way down to the ankle. This image accurately portrays diffuse axial reflux. The source of reflux in the great saphenous vein displayed in this image is junctional. The blood is flowing retrograde down the thigh portion of the great saphenous vein and exiting into a more superficial source. In this case, it is a distal thigh great saphenous vein tributary. In the next 2 slides, we are going to look at 2 patterns of great saphenous vein reflux that almost always cause confusion: short single segment reflux and multi-segmental reflux. In both cases, there is a non-refluxing saphenofemoral junction. The diagram on the left displays mid-thigh segmental great saphenous vein reflux caused by an incompetent tributary that joins with the great saphenous vein at the distal thigh, resulting in a short segment of reflux found in the great saphenous vein at the distal segment, which then exits out into a below-knee tributary. The diagram on the right displays distal thigh segmental great saphenous vein reflux caused by an incompetent tributary that joins with the great saphenous vein below the knee, resulting in reflux found in the great saphenous vein from the proximal calf to the ankle. These 2 diagrams are displaying multi-segmental reflux found in the great saphenous vein. Multiple incompetent tributaries are joining with the great saphenous vein, causing reflux to flow in and out of these short segments. Is this great saphenous vein incompetent? Here are a few patterns of small saphenous vein reflux, some diffuse and some segmental. In all these situations, we must ask again, is this genuine axial vein incompetence, or is the cause of the reflux a result of overload from another source? The source of the reflux in the distal segment of the small saphenous vein displayed in the image on the right is not junctional. The reflux found in the distal small saphenous vein is caused by an incompetent great saphenous vein and a tributary of the great saphenous vein. The take-home message here is this is not genuine small saphenous vein incompetence. This is a crossover pattern known as crossover reflux. The reflux found in the small saphenous vein is caused by an overload from another source. You must always ask yourself the question, is the incompetence because of an overload, or is it the cause of the overload? In this particular scenario, many times after treating the source of the great saphenous vein reflux, the small saphenous vein will become competent. This is a thigh extension demonstrating reverse flow dumping into the popliteal vein. This was an incidental finding while performing a routine lower extremity reflux examination. The patient presented with medial malleolar telangiectasia, but back in the early 90s, before corona fabricatica was clearly defined, ultrasounds were routinely ordered. Unfortunately, our lab did not have a color printer, so you will have to trust my arrows displaying the retrograde flow. So the question here is this reflux or normal venous return? In this photo, we have a cluster of varicosity seen in the popliteal fossa. The small saphenous vein is clearly not the cause of the varices. However, many times, these varices will cause reflux to dump into the sapheno-popliteal junction, and the small saphenous vein will be labeled incompetent. There are also multiple pelvic loop points that may be the source of reflux found in the lower extremity, but we will leave those for another talk. So in conclusion, these are the questions you want to ask yourself when performing an ultrasound examination. Was reflux elicited in the proper position? Where does the reflux begin and where does it end? Is the reflux originating from a pelvic source? Was the reflux measured correctly? Is the reflux relevant? Are reflux and retrograde flow the same? Is the reverse flow found simply normal venous return? Is the venous reflux a result of overload from another source? Are the visual varices caused by axial vein incompetence? Should axial and segmental reflux be treated the same? Does it coordinate with the clinical picture and or the patient's symptoms? Successful vein mapping for superficial venous disease requires meticulous attention to detail and a fair amount of patience, and I do thank you for yours.
Thank you very much, Linda. That was a great lecture. I will take over because Sarah has some trouble already. I will just wait for the final questions after the last presentation that we have with Dr. Erica Mendoza. If there is some stuff, please just let us know after we finish the presentation. Mr. Peñafiel, Gustavo, ¿podemos pasar la presentación?
Okay. Dear ladies, thank you for this opportunity of participating from Europe on this wonderful program, EmPowHER. I want to talk about my lovely topic, perforating veins, which is really one of my heartiest items. I have no conflict of interest to this topic. Just to remember, the perforating veins were renamed, and these are the perforating veins of the upper thigh and of the medial thigh. And the old names were Dodd and Hunter and Boyd, and I love them because they are very short. But just to know, these ones are the most important ones on the saphenous veins, and those are the most important draining the saphenous vein, the great saphenous vein, and we have those on the posterior part of the calf, which is the which is the gastrocnemius point, the most important one draining or feeding the small saphenous vein. So when we study the perforating veins in the leg, we do not have to find each perforating vein just because we know it is there. Also in phlebography, if we have a look at this image, this is the deep vein, the femoral vein, and this is the great saphenous vein with a reflux until this point, escaping here to the tributary. This is the tiny, healthy distal saphenous vein. And we know here are at least 3 perforating veins, but they are not part of the recirculation. Blood with the contrast medium fills the recirculation, and these perforating veins are not escape points and are not re-entry points. They are not contrasted, so they are irrelevant to the phlebologic investigation. So we have only to investigate those with a large visible diameter. How do we investigate? We investigate in standing position, where we will find little or no flow in the superficial veins, and we have to provoke it. This can be done with this manual compression of the calf or with the muscular contraction, for example, with the toe elevation. And this is called muscle systole. And then we wait what happens when we release the calf or we put down the toe again, and then we see what happens in the muscular diastole after the relaxation. This is the most important phase of the flow. And we investigate the fate of the flow after it has been propulsed upstairs. If we have competent valves, the backflow will be less than 0.5 or 1 second, depending on the school. My school is 1 second. And if the valves do not close, the blood will flow a long time backwards. And this will mean it will flow footwards through the saphenous vein and then will re-entry somewhere into the deep vein. And sometimes it will be the escape point. It will come out of a perforating vein and fill the vein. But not every dilated vein is a guilty vein filling the recirculation. To have a little remember of physiology, this is a deep vein at rest. In systole, we push up the blood. In diastole, when the valve is closed, there is no reflux. And this, we will represent it like this: systole, diastole, no reflux. If we have a combination of the deep vein and the superficial vein, this is the deep vein, this is the superficial vein, at rest, at compression, and then at rest, in diastole, we see there is no retrograde flow, neither in the deep vein nor in the superficial one. And in the diastole, there is a short drainage from the superficial to the deep. It is different when we have a recirculation due to a incompetent proximal valve. This is the case of the great saphenous vein with the terminal insufficient axial reflux and a re-entry through a distal perforating vein. So in systole, we push up in both the blood to the heart, and in the diastole, in the deep vein, there is no reflux, but through the terminal valve into the great saphenous vein, and it reflows until the distal re-entry vein where the blood goes in. And then in the diastole, in this rest phase, we will see a long-lasting inwards flow. This is like this image. You have a systole when you measure here, and you have a long-lasting reflux in diastole. This is the reflux. And if you look at the same recirculation thing at the re-entry perforating vein, you will have in systole and diastole an inwards flow, draining, even though the perforating vein is really wide. It's opened. So if you find a flow towards the deep vein, especially in diastole, you can be sure that this vein is only draining. It is not guilty for the recirculation. Different is it when we have the perforating vein as an escape point. This is the case. You have a small saphenous vein here, a large one here, and here you see the perforating vein. And schematically, you see from the deep vein outflow and into the great saphenous vein at this part. If you see the thing in color-coded duplex, you see in the diastole that there is an outflow through the perforating vein. And this is also shown in an image here in PV mode. You have a systole inwards flow, and in the diastole, an outwards flow returning from the deep vein to the superficial vein. This perforating vein is guilty. This is feeding the superficial venous reflux. Then we have here a little movie showing perforating vein in the fossa poplitea. And the question is this a reflux in diastole and systole? And you have all already seen this is systole and diastole, and you have a long-lasting red reflux towards the superficial venous system in diastole. Last show, again, systole, everything is blue, diastole, reflux from the deep vein through the perforating vein to the superficial venous system. So again, this image, you know it already. We have a reflux, a recirculation, we have a re-entry here, and we have a wide and open vein, but we have only a drainage flow in diastole. This one is also a paratibial vein, typical one, distal in the calf, and with a re-entry in diastole, and this vein is not pathological. We remember this image. This was the proximal reflux point, but not all the refluxing perforating veins have to be the origin of a recirculation. We can have another situation. We can have an obstructed deep venous system. And what happens then? Blood flow can't ascend through the deep vein and finds its way through a perforating vein, for example, the proximal paratibial or antique, we said void, and it goes out here, the blood goes up through the saphenous vein and goes into the deep vein system, making a bypass, a vicarious shunt or a bypass to the deep venous system. And so we have a distal small superficial vein, a refluxing perforating, and a proximal wide superficial vein, but with draining flow in systole and diastole. So if we find a reflux through a perforating vein at the calf, we always have to be aware of a problem with the deep veins, of an obstruction or a reflux. A very seldom situation of perforating vein can be a bone perforating vein. It's just seldom, but it has been shown that the reflux emerges from the tibial posterior vein and goes through the to the medulla in the bone and emerges somewhere. And most often, in my experience, it is an old fracture or indentation of the bone that you can here very well see in the periost. And then there is a blood emerging directly from the bone. And as you can imagine, this is very difficult to close surgically if you have not cement to close it like you need for bone surgery. And I recommend doing sclerotherapy for these cases. So the summary, if you only have to study the dilated perforating veins, most of the dilated veins will be re-entry perforating veins, and you will have an inwards flow in diastole through them, and they finish the recirculation, bringing the blood back to the deep venous system. You very seldom will find a dilated perforating vein as the proximal escape point of the recirculation. You have to be careful. If you in systole and diastole have an outward flow, you have to think of a deep venous obstruction or reflux. So thank you for your attention. If you're interested in further information, I can afford this one options to read more of my love, the duplex ultrasound. And now I hope to join you in the discussion. Thank you.
Really was a great lecture. Thank you very much to many of you. I will just open the mics for questions and answers, just also for comments. Dr. Mendoza, thanks for your lecture. It was really great. And we saw that the weather over there is beautiful.
Yes, thank you. I just left another Congress I organized. I just finished and sit at the outside to share with you this important moment. Thank you.
Okay. Please, if any of you can open your mic and raise your hand and tell me some comments or questions from the panelists, please. Okay, I have just a small question to Linda. Linda, I saw that you are talking about the way that you are working in refluxing veins and everything. What is your final recommendation regarding about your lecture?
Well, my final recommendation, you mean as regarding treatment? Because I'm a sonographer, so I do not perform treatment. But what I do is I try to represent as accurately as I can, thinking of the patient's limb and thinking of the entire picture, the clinical picture, and what the patient's complaining are. So I want to represent most accurately on my mapping exactly what I'm seeing. So I don't want to call great saphenous vein incompetence when I just have a small bit of overload from the knee down because of an external tributary coming from an outside source. So that's what my take-home message is, that we should provide the physicians or any provider with an accurate mapping as best we can. I hope I answered your question, Dr. Kanata.
Yeah, excellent. Was a very good. I have another question for from all of you. They have a question from the QA answer. There is it's a difficult one. He said, "What we supposed to do for a patient who cannot stand for their venous insufficiency study? What we can do for that, and what are your choices trying to give us a good result of your test?"
If I may answer first, I try to ask a second person to stand behind, and then the person sits on the in the bed and reclines back, and somebody is holding, so you can go into the groin and make all the rest in sitting position. Or do you mean the person is recumbent, is lying down? If the person is lying down, you can help because Valsalva is very difficult, and the only option you have is to do Valsalva for a deep venous insufficiency. I put my hand on the stomach and say, press against my hand. So I help them just to kind of do any kind of Valsalva, and then you have to investigate in supine position.
May I
Now,
jump
Linda,
in?
what
Yes,
are your
I would agree with Dr. Mendoza 100%. If they cannot stand at all, then I would use gross reverse Trendelenburg with a footboard or something to make sure they're safe. If they come in with a walker, I scan in between their walker and I have the table behind them so they are well supported and always safe. Many times I'll do one leg, let them sit, and then do the other, and then maybe do the calf portions, letting them sit down. You know, we have to work around the patient's limitations, but I think to do a normal patient supine is negligence.
Lori, Dr. Pound?
Yes, sir.
What are your choices regarding about that? We would like to see your tricks.
One more time.
Yeah, because the trouble is the patient cannot stand up. What are your choices to do a better sonogram for the patient?
Well, I think I agree with how the panelists are doing it. We certainly have the, stretchers that have the footboards for the deep reverse Trendelenburg, and looking for it, ideally for some, if they can't stand or that they're that debilitated, or depending what we're looking for, if it's for edema or whatnot, we've actually even stopped doing some of the reflux studies at our institution just because our texts are so precious and it's such a laborious study. If they're not a candidate for an ablation because their BMI is, 60 or they're wheelchair bound or things like that, we've actually even stopped doing some of the aggressive testing because, again, it's really hard on the techs to do all that. But, if somebody, again, is ambulatory and whatnot, we do try to get them up and stand them up as much as possible. I agree with that. I think the Valsalva, it can be too variable between sonographers and not say sonographers, but the patient. Patient contributing to that, it could be a, or it could be a, and so I don't really like to trust that if I don't have to.
That's any of you are using a tilted table that
Yes.
your table in your office, just putting down your patient and holding with two restraints in the middle, because it's just some kind of stuff that you can use it. Dr. Hedayati, do you have a question regarding about that? Some comments?
I agree with everyone. I think the other important thing is we always make sure that those studies, because they are so time consuming, they're scheduled for 2 hours, because it's not as simple. You know, we get patients who come in, we've never seen, they're like, well, can you do the study today? And the answer is no, it takes 2 hours. It's a long test. And we certainly, the other thing, as Dr. Pound said, you know, some patients shouldn't get a reflux study. I mean, there are patients that you think are going to benefit if they have an ulcer and they're morbidly obese. Okay, you do the best you can because you think, okay, there's something I can treat. But if it's a non-ambulatory patient who's morbidly obese with leg edema, I mean, sometimes maybe it's just not worth it, because no matter what you do to their veins, their leg is not going to be their legs when they're 20 years old. And I tell them that they may just need really good compression and elevation. So it's best to be, as Linda was saying, you want to do what's safe for the patient. So if you can't tilt and you're going to get a study that's suboptimal, I mean, I had a patient who was like 500 pounds, and I was like, it took two techs to, and you know, she's ambulatory still, and she had all these issues, but it took 2 techs to kind of look for reflux. So you have to be really realistic about, is it even worth, you know, doing some of these studies? And you want to be safe, but it also is very time consuming on your techs, and you want to be cognizant of the ergonomics it's going to put the techs on. So
if I may say something to this, if I have a patient with morbid obesity, and they send them to me to asking for thrombosis, and they have a big edema in one leg, for example, then I sit them down at the border of the examination place, and I check for the popliteal vein, which is normally available anyway. And I assume if in the popliteal vein moving the foot, there is a good flow upwards, I assume that there is no thrombosis. And I go by D-dimers, popliteal vein examination, distal tibial posterior vein, and no more, because I can't say that I will find any deep vein, any other deep vein.
Before we finish, Dr. Mendoza, they asking for if you can tell us how do you do the Paraná maneuver?
How I do the Paraná maneuver?
Paraná.
Yes, I normally do not do the Paraná maneuver, because the Paraná maneuver is pushing the patient. When you are investigating the back of the patient, you push him slightly and the gastrocnemius vein contract, so he evacuates the blood. And if he's looking to you, you pull a little bit from the patient. But I developed the so-called Wunstorf maneuver at the place where I live, which is now called toe elevation maneuver, because I thought how to activate the gastrocnemius veins without pushing a patient who is standing on a elevated place and perhaps is old and has fears of falling down. So I think Paraná was the first physiologic maneuver described in Paraná by Franceschi, but I nearly never use it because I prefer doing toe elevation.
Okay, I think we are done already. There are some comments from any of you. Please, I open the mic for 1 minute comment. Dr. Pound, do you have something for us? Dr. Hedayati?
No, there was somebody who had asked about accreditation and why do the lab accreditation. The university lab is accredited. The VA, actually, we are not accredited. You can have accreditation in one module and then, you know, go across. It does take time and money for sonographers, but it just generally implies quality. And so when trying to convince people to pay for it, like the VA, you know, the money and time, it is hard to convince them to do that. And at this point, you know, I keep hearing back and forth, there's going to be the threats of you have to be credited to bill and everything. But as far as I know, I keep hearing different things. It's not a requirement to be accredited to bill Medicare for tests. And maybe Dr. Hedayati has an update on that. I was trying to look up some of that, but it's always thought.
Yeah,
Thank you.
I mean, I agree with Dr. Pence. I mean, we are accredited at the university, not at the VA. It is really time consuming. And of course, it's costly. And of course, at a place like the VA where they're always trying to cut costs and it's so expensive to do anything. I do agree with you. It is really time consuming and it's more about quality, not really anything else. But I mean, even at the VA without the IAC, we still do our quality metrics and have quality assurance conferences to, look at our ultrasounds. And, if I pick up stuff that my text did that just don't make sense, I make a list of it and go over the ultrasounds with them, the way they read stuff or the things they missed and stuff like that. I think it's important to have some measure to keep, being able to compare the ultrasounds. When we injure someone, we kind of compare the ultrasounds to see how well we pick up stenosis or things like that. But it is a pretty labor intensive process too. So, but at the VA, of course, we're not held up to the same kind of standards as other payers would be in different hospitals.
Okay, thank you very much. I will not just to hold you anymore with this period of Saturday that we have right now. From the board of Bain University, we are so happy to have you working up here with us, and we will just like to invite you for the next webinar. Will be next October 2nd. Mr. Peñafiel, can you just pass the message of Dr. Onida, please?
Repeat, doctor.
Sí, el mensaje que te envió y la foto que te envió la doctora Onida, por favor. No, déjame compartir pantalla a mí.
Lo tiene para compartir.
Bueno, okay, the next will be, our next webinar will be in lymphedema, and we're just more than happy to just start working, and we'll share just a short screen. This is our next session, will be Saturday, October 2nd, and we'll be more than happy to have you. And again, I hope all our efforts will be changing in the near future, and we will be able just to join and again together in a personal meeting. And again, thank you very much for all of you. You really work very hard, and we will see each other in the near future. From the deep of our heart of you, Dr. Lowell, Kadney, and me, we just want to say thanks. We will keep pushing because you have the power to change everything, and we are thank you very much for all your efforts. Teaching is the way that all our patients and everybody else will be able just to evolve and have more expertise in the field that you are sharing right now. Thank you very much, and I hope you have a very good and excellent weekend.
Thank you.
Thank you. Thank you so much.
Thank you. Bye-bye. Thank you
Bye.
for organizing. Bye.
Thank you.